Welcome to the Heart and Vascular Institute's webinar series. This is the inaugural webinar tonight. We're going to talk about revascularization in coronary artery disease. But this is one of the first of the 6 webinars that will cover all aspects of cardiovascular medicine and surgery. And the unique part of this, although Cleveland Clinic Abu Dhabi organized this meeting, we are proud to say that all Cleveland Clinic entities contributed to this effort. So we have participation from main campus Cleveland Clinic in Ohio, USA, similarly from Florida Cleveland Clinic, in Canada, Toronto Cleveland Clinic, in London, Cleveland Clinic London. And we are very, very proud to have these contributions. And this is not complete, because we also have Cleveland Clinic Nevada, our brain and neurology center there that will contribute and talk about the link between the brain and the heart in the upcoming preventive meeting. So without any further ado, I would like to start today's session that is titled Revascularization in Coronary Artery Disease. We're going to have 10-minute talks followed by 5-minute question and answer and commentary. I very much am looking forward to your questions and participation to the discussion. We have a distinguished panel from main campus Cleveland Clinic, as well as Cleveland Clinic Abu Dhabi. So let me go ahead and introduce to you Dr. Firas Al-Badr. Dr. Al-Badr is a consultant physician at Heart and Vascular Institute in Cleveland Clinic Abu Dhabi. We were privileged to be able to recruit him from Mid-America Heart Institute. Beforehand, he was in Northwestern University in Chicago. His area of expertise is imaging. He has done a lot of outcomes research involving epidemiology as well as cardiovascular imaging. He's a top expert in various imaging modalities, and specifically PET scan, and then sophisticated use of PET scan imaging, and his research is in that direction, among others at this time. So Firas's talk is Stable Coronary Artery Disease. This is one of the 2 starting talks, and his title is Stable Coronary Artery Disease, Medical Therapy is the Best Choice. Firas, welcome and thank you. The floor is yours.
I would like to thank the organizers for this opportunity. My name is Firas Al-Badr, and I'll be discussing the role of medical therapy in management of stable coronary. I would like to thank the organizers for this opportunity. My name is Firas Al-Badr, and I'll be discussing the role of medical therapy in disease. I have no relevant financial disclosures. Let's start off with the case of a 70-year-old male who presented to the office for evaluation of exertional dyspnea, typically triggered when he climbs stairs or walks to a nearby mosque. His symptoms are similar to what he experienced several years ago when he required PCI to the right coronary artery. He has a background of hypertension, hyperlipidemia, and is a prior smoker. He's compliant with his medications, including low-dose aspirin, atorvastatin, and bisoprolol. His blood pressure in the office was 126/81, and his heart rate was 76. With regards to management, due to his past history of coronary disease and his limited exercise tolerance, I opted to evaluate him with a vasodilator, PET myocardial perfusion imaging. His PET MPI shows a medium-sized area of severe ischemia involving the anterior segment of the left ventricle in the mid and basal segments, without involvement in of the left ventricular apex or the left ventricular septum. This is likely suggestive of ischemia in a diagonal branch. 21% of the LV mass was felt to be ischemic. The left ventricular ejection fraction was normal at rest and augmented appropriately in response to hyperemic stress. His myocardial blood flow reserve was also intact at 1.9 times baseline. In light of these findings, the question comes up is how should this patient be managed? And the options are to proceed with invasive coronary angiography and perform coronary revascularization as needed, versus optimizing medical therapy, especially that there is room to add additional anti-anginal medications. The debate about the equipoise of medical therapy to revascularization in management of stable coronary artery disease is not new, and it dates back to at least 40 years ago, the earlier days of coronary artery bypass surgery. And data such as those presented suggest that medical therapy is highly successful in the management of stable coronary artery disease and is associated with low mortality, denoting that this debate has been going on for several decades. But why should this debate be there in the first place? Well, there are several arguments that can be used in favor of revascularization in management of stable coronary disease, such as reduction in the risk of death or myocardial infarction, especially in patients with proximal tight disease. Patients in high-risk subsets of patients may derive incremental benefit from revascularization, and the argument that quicker relief of angina can be achieved with revascularization. What does the literature say in this regard? This is data from the COURAGE study dating back to 2008, including 2,300 patients with stable coronary disease randomized to optimal medical therapy versus optimal medical therapy with PCI with bare metal stent. And it shows there was no difference in the study endpoints of death from cardiovascular causes or myocardial infarction. However, there are several criticisms for the COURAGE study, such as exclusion of patients who were likely to benefit from revascularization and the use of bare metal stent, which may not be relevant to the contemporary practice of percutaneous coronary interventions. These criticisms are valid, and it took us more than 10 years to design and properly conduct a study that is relevant to the current practice in stable coronary artery disease, which is the Ischemia trial, where 5,200 patients with moderate to severe ischemia by core lab interpretations were randomized to a strategy of an invasive strategy where invasive angiography and revascularization was performed up front versus optimal medical therapy and referring to angiography only for failure of medical therapy due to intractable angina. Patients with left main disease were excluded with a blinding coronary CT angiogram, which also confirmed the presence of obstructive coronary artery disease. Patients in ischemia were not low risk by any chance. 50% of patients had proximal LAD involvement, 40% had diabetes, and 40% had multivessel disease. However, there was no difference between the two strategies at the end of 3.2 years of follow-up in terms of cardiovascular death, myocardial infarction, or hospitalization for unstable angina or heart failure or resuscitated cardiac arrest. However, there was a 2% excess in risk seen in the invasive strategy early on that was counterbalanced by a 2% excess in risk seen in the conservative strategy later on. It turns out that this difference was triggered by the difference in myocardial infarction, such that peri-procedural myocardial infarction were more common in patients in the invasive strategy early on, which was balanced by an increase in risk of spontaneous myocardial infarction in patients in the conservative arm. One of the arguments that may be brought up is that these are small myocardial infarctions, peri-procedural MIs that may not be prognostically significant. However, I would like to draw your attention to the stringent and strict definitions used by the investigators for myocardial infarction. The totality of evidence in this meta-analysis of almost 15,000 patients confirms that routine revascularization in stable coronary artery disease was not associated with improvement in risk of death, cardiovascular death, or total myocardial infarction. And again, there is a demonstration of a 25% reduction in the risk of spontaneous MI at the price of a 2.5-fold increase in the risk of procedural myocardial infarction. In the ischemia trial, there was no heterogeneity of treatment effect by the extent of myocardial ischemia, anatomic extent of disease, and whether there was or there was not involvement of the proximal LAD, suggesting that these features did not modulate the benefit of revascularization on the endpoint. Data from the Berry 2D study shown here shows that even in a patient in a population of diabetic patients with stable coronary artery disease, again there was no difference in hard endpoints of death or myocardial infarction with routine upfront revascularization. And similar data that will not be shown due to time constraints from the Ischemia CKD study shows that even in that population, no difference was seen with routine revascularization. How about prompt symptom relief? Again, this is an argument that's used to in favor of coronary revascularization, and it's data from Courage study shows that there was 25% more patients in the PCI arm who were angina-free after revascularization compared to optimal medical therapy. However, when you look at 2 and 3 years, this difference between the two arms diminishes and is ultimately gone, perhaps related to gradual improvement in quality of life in patients randomized to optimal medical therapy. This is data from Ischemia trial showing that it is actually patients with large burden of angina at baseline who were more likely to benefit from invasive strategy, whereas those with minimal angina, there was no difference between the two arms. Again, showing that it is the burden of angina at baseline that drives the benefit. The difference was lost at 36 years once again. But keep in mind that Courage and Ischemia were not blinded. And this brings up the potential question is whether this improvement in quality of life is related to a placebo. There's very interesting data from the Orbita investigators where patients were randomized to either optimal American therapy plus PCI versus optimal American therapy plus a sham-controlled procedure, and showed that there was no difference in the quality of life at the end of this study at 6 months. Suggesting that this might be, the difference in quality of life might be related to placebo. The argument about cost effectiveness again doesn't hold true, and this is a cost effectiveness analysis from the Courage study shows that routine PCI is at best more effective but more expensive compared to routine medical therapy. So as I conclude, patients with stable coronary artery disease, both optimal medical therapy and coronary vascularization offer comparable protection from cardiovascular events. Routine invasive strategy is associated with higher periprocedural MI, whereas a conservative strategy is associated with higher spontaneous MI later on. Upfront revascularization is superior in achieving quicker angina relief, and that upfront angiography should indeed be reserved for patients with left main disease or unacceptable levels of angina. Let's take it back to our patient who actually didn't come to my office asking for PCI to his diagonal branch or to be put on IMDOR. He actually came in with symptoms. He wanted to know what is causing his symptoms, and whether or not he will be okay, and he wants to resume his activities. So I can tell him that your symptoms are caused by myocardial ischemia, as demonstrated on his perfusion scan, and that with regards to the endpoints, there is no rush for angiography at this point in time, and that we can optimize his medical therapy, and we can always revert to an invasive strategy if quality of life does not improve. So the evidence-based management of stable coronary artery disease in 2021, we need to know the evidence, we need to use the facts, not fear. We should have courage, and we should push medicine. Thank you so much.
Thank you very much, Feras. Wonderful presentation, and we are waiting for comments and questions. Please do enter, and then we're going to be asking the same questions in real time. Feras, can you hear me?
Hi, Dr. Pisco.
Yes.
Yeah, it seems that Dr. Firas has been logged off online, and we'll try to put him back on, and then we will address the questions later on.
Okay, yes, we are. maybe in that time period, we will also look at if we got some comments or questions from the audience.
Okay.
All right, Faraz.
All right, so
Okay.
apologies for this.
No problem at all. Now, a couple of questions come to mind. You didn't mention the crossovers. Were there crossovers? And then, and what was the timing in the ischemia trial? Does that bring any reasons to think that there may be not as clear a black and white distinction between the two therapy modalities, but perhaps we should also think it in some complementary way. What do you think?
Thank you, Dr. Tuju. This is a great question. There was actually a crossover from the conservative strategy to the invasive strategy. 28% of patients crossed over for either an event, an antecedent event, or refractory angina. The majority of them, though, were failure to adhere to the protocol. Of those 28%, the majority received percutaneous coronary intervention, such that it ended up that 20% of those patients received revascularization. We need to keep in mind that also in the invasive strategy, there were 20% of patients who did not receive revascularization despite being in the invasive arm. So overall, I think the crossover was equal and balanced in both directions. I don't know, with regards to the second question, if we were to extend the study further, or if there will be a longer-term follow-up, if we will continue to see divergence of the curves in favor of the invasive strategy to be completely neutral here because of the issue with spontaneous myocardial infarction. So to answer your question, as it stands today, I think there is equipoise, and the data is convincing. Whether longer-term data would change our conclusion, that remains to be seen.
I have some very provocative questions. One of them is, I'm quoting, so does that mean that intervention cardiologists will no longer be needed unless for the two situations mentioned in the conclusion?
No, we will always need our interventional colleagues, but we have to think about the spectrum of cardiovascular disease. We have acute coronary syndrome, acute myocardial infarction, where there is absolutely no question, the data is incontrovertible that percutaneous coronary intervention in this setting is superior to medical therapy. When it comes to stable coronary artery disease, however, it is more, the data is convincing and compelling that there is no rush to proceed with invasive angiography and revascularization. We have to give medical therapy a choice, and we have to counsel our patients such that there's no rush, there is no urgency or danger to them. So we always will need you guys.
Okay, I'm gonna ask, there are several more, I won't be able to ask all of them, but please, succinct answers. Sure. What is best strategy for mildly symptomatic proximal LAD disease?
Medical therapy. Early on, medical therapy, and failure will go to angiography.
What about if the patient is mildly symptomatic, no evidence of instability, but the flow is not TIMI-3?
So that probably suggests that we are either dealing with an acute coronary syndrome, in which case PCI is superior, or that this is more of a chronic occlusion, in which case, deferring revascularization may not be unreasonable. Okay.
Is there an absolute indication of invasive therapy in case of chronic coronary syndrome? One answer. Is there an absolute indication?
Yes. We're clinicians at the end. Yes.
Okay. All right. Angina, for a young person, late 20s, female, one child, what could be the best intervention to be done?
Well, you have to keep in mind the non-atherosclerotic causes of coronary disease and chest pain, spontaneous coronary artery dissection, other etiologies. So depending on the scenario, we may need invasive or non-invasive coronary angiography to assess the morphology and the extent of coronary disease involvement. Okay.
Well, thank you so very much. And we're going to proceed now with Dr. Mahmoud Traina, the section head of interventional cardiology and director of the cath lab at Cleveland Clinic Abu Dhabi, originally from University of California, Los Angeles system. He's going to talk and then, in a way, debate with the previous talk. Let's go ahead and get started.
Tuesday for having me. My name is Mahmoud Traina. I'm going to be speaking about stable CAD and why PCI should be done. So I have no disclosures relevant to this talk except for the fact that I'm an interventional cardiologist. So take that for what it's worth. So we'll start with a case. So a 63-year-old male with history of hypertension, hyperlipidemia has been having ongoing chest discomfort for a little bit of time, for a few months. Nuclear scan was ordered by his cardiologist and it showed a small reversible perfusion defect of mild intensity in the mid-anterior lateral wall. So not a big concerning defect. They decided to optimize his medical therapy. He's now on a high-dose calcium channel blocker, high-dose beta blocker, and a long-acting nitrate. However, his symptoms have persisted in spite of this. He likes to garden, so he has to take breaks during his gardening, which is his favorite hobby, and kind of doesn't get out as much since these symptoms have started. So he was referred for a cardiac cath. So this is angiogram. He has an LAD with a 70% or so proximal lesion, otherwise no significant disease. So the question arises, what should you do based on the current data? I think before we need to step back is, why do we do any intervention in medicine at all? Well, we do it to improve survival. That's obviously a critical goal. We also do it to prevent future events. Many therapies are done to prevent events in the future. Statin therapy for primary prevention is one of those. But also, very importantly, and many fields of medicine are based on this, is to improve quality of life. And that's a fundamental goal in our treatment of patients. So one of the big trials many of you will remember is the COURAGE trial, came out back in 2007, in which they took patients with stable CAD and evidence of ischemia and significant coronary disease on angiograms. All patients had angiograms before enrollment, and randomized them to PCI versus optimal medical therapy. And it showed no difference in death or MI as a combined endpoint, and no difference in overall survival with PCI. And people started to say PCI should not be done. However, if we look at the COURAGE trial, of the patients assessed for the trial, 35,000 patients, they only enrolled 3,000 patients. So 92% of patients were excluded. This is a trial many interventionalists have used over time, but a lot of them were based on persistent angina, reduced ejection fraction, patient having significant left main, and a lot of these decisions to even assess them for the trial were done after angiography. So there's questions whether patients were being excluded because of significant atherosclerosis that people didn't feel comfortable intervening, leaving alone. So that was kind of the running point until we came up with the Ischemia trial, which was published last year. Very well done trial. They improved the design, so they did not use angiography prior to randomization, and targeted patients with significant ischemia. So it took patients with stable angina, moderate to severe ischemia on stress test, over 5,000 patients, followed up for 3 years. Anatomy still had to be known so we can exclude out high risk findings. So cardiac CT was done to rule out left main, and also patients that had non-obstructive disease and causing their angina. And this trial, followed out to 5 years, showed no difference in MACE, death, or MI. So again, as I'm sure was presented already, point is, should we be doing intervention on any of these patients? However, we do know, it's well-established fact, that PCI does relieve angina and improves patients' freedom from anti-anginal medications. This is from the COURAGE trial, showing that PCI combined with medical therapy reduced patients' uses of nitrates, significantly reduced their uses of calcium channel blockers, and this is despite about a third of patients crossing over to PCI in the optimal medical therapy group. And on top of this, it's very important to remember that these all are done as strategy trials. So this is an initial strategy with a decision to cross over later. So in COURAGE, again, a third of patients crossed over. And if you looked at it, most of the patients that crossed over were those that were having frequent angina. So, which makes sense. So patients that are having no or very rare monthly angina probably can get away with medical therapy and don't need a PCI to relieve their symptoms. But those that are having weekly or daily angina, the crossover rate dramatically increased. So if we combine all these trials, so now that we have about a 25 to 30 year history of trials looking at this stable CAD patients, excluding high risk anatomy, and looking at a planned revascularization strategy versus medical therapy. And in these trials, we have over 15,000 patients, or close to 15,000 patients. Almost all have normal EF, no left main. All the trials did some sort of process to exclude left main. And the vast majority of patients were Canadian class 1 or 2 angina, so excluded the severe anginas. And in the routine revascularization arms, about 71% got PCI, 16% got CABG, and about 12 to 13% got medical therapy. So 87% received the revascularization arm. In the initial medical therapy arm, still about a third of patients still got revascularization for ongoing symptoms or whatever other indication later happened during the follow-up. So it wasn't a definitive one or the other in these trials, but it's a strategy to approaching the patients. And if we look at the combined endpoints, so if we put all these patients together, revascularization for stable CAD, when you exclude high-risk anatomy, does not improve survival. And I think that's kind of issue can be put to bed in general. And this is, again, across all these 15,000 patients. What does revascularization do besides treating angina? Well, it does reduce spontaneous MIs. It does seem to reduce unstable angina, but it increases procedural MIs. And that's the net kind of equation we are dealing with. So when we look at this meta-analysis overall, over 65,000 patient years of follow-up between these patients, about a third of patients in an initial medical therapy strategy convert. So it shouldn't be dogma that you tried medical therapy, then that's medical therapy for life. If patients have ongoing symptoms or increasing medications, it's very reasonable to pursue the PCI option. Survival is similar, and we shouldn't be ever quoting for these patients that we will improve their survival. But it does reduce non-procedural MI in follow-up. It does reduce unstable angina events, and patients have greater freedom from angina. But it does increase procedural MI. And so that's kind of the overall take-home with PCI and stable CAD. So if we're talking about the primary benefit in stable CAD of obtaining optimal results for these is angina relief, then really optimizing our results becomes of utmost importance because we can't be achieving suboptimal results for these patients. Routine use of FFR has been shown to improve outcomes. So this is the FAME2 trial, which has some issues with the design, but we see that PCI versus medical therapy significantly reduced the rates of the composite endpoint, primarily driven by unstable angina events. But the PCI arm equally showed similar to patients that had negative FFR. So we were able to achieve results as good as patients that have no significant disease when we use routine FFR in selecting the appropriate lesions to treat. Stent optimization, I think this is a worldwide issue where we have now 25 years of data, over 31 trials, over 17,000 patients enrolled in these trials. And I think we can pretty definitively declare that routine IVUS usage reduces MACE, reduces cardiovascular death, and reduces target lesion revascularization, and should become performed in the majority of cases, especially when there's more complex anatomy. Recent studies even suggest that when we use stent optimization with IVUS or OCT or other imaging techniques, we can reduce restenosis to less than 2%. And I think that becomes of increased importance when we're talking about a therapy that does not improve survival. So back to our patient. He had FFR of his LAD lesion was 0.72. He underwent OCT guided PCI with placement of a Zion Sierra stent, 3.5 by 23, is post-dilated. We achieved an MLA of 8.1. His nitrates were stopped in follow-up. His calcium channel blocker and beta blocker doses were reduced. And he returned to gardening without limitations, and his quality of life improved. So my final thoughts. I think the era of blind oculostenotic revascularization should finally be over. We treat patients, not angiograms, and I think we need to go back to our roots in the interventional community of being physicians and treating these patients. We don't, orthopedic doctors don't replace knees based on x-rays, they replace them based on patient symptoms. Outside of left main and severe three vessel disease, revascularization really should be guided by patient symptoms. The stable CAD trials are strategy trials, they're not dogma. So 1/3 of patients in the conservative arms of these trials received revascularization. Improving quality of life is a rational, noble aim for therapy. Entire fields of medicine are based on this. I don't think that's a unreasonable reason to perform a procedure and to do an intervention on a patient. And I think that's a very good goal for therapy if it's appropriate. But we need to really do a better job as a community of optimizing our results with low MACE. And I think the data is very clear that regular use of FFR, intracoronary imaging with IVUS and OCT, and stent optimization are critical in giving our patients the best results possible. Thank you.
Thank you very much, Mahmoud. Please stay on the line, and then we're again open for the comments and the questions. Let me just start by asking you a question. Firas Al-Badrin and you are working in the same unit, and do you always disagree about how to manage stable angina patients? How do you go around managing your patients if you have almost dichotomous, sort of almost the opposite viewpoints on how to approach these patients?
I thought it was interesting because I just saw his slides for the first time, and so we actually almost used the exact same articles and slides in our presentations. We actually agree 90% of the time. So I think we practice in a style, and I think we both do. And as this ancient belief that every lesion should be treated, and every vessel that has a narrowing of over 70% needs a stent. Just goes against the data. So I think that's been very clear. Then the question arises is, at what point is medical therapy and what level of medical therapy is reasonable? So I think we have a healthy discussion on a regular daily basis, discussing cases and what to do about each patient. And I think as long as we're all clear on the endpoints, then it becomes a patient and a physician level of discussion of what's best in each case.
Okay, and we have very limited time, so I have only one more question. Now you are talking about the IVUS and the OCT and FFR. Well, it's going to take lengthen my procedure. I can go ahead and put a stent in, or even 2 stents in less time than I will spend with this other modalities. Number 2, I'm going to pay a lot of money from that, and then DRG is fixed many times. So how should I go about that? And what percentage of your patients, by the way, you do FFR and IVUS?
So, I think these are issues of the way a lot, especially in our region, a lot of what payment happens is based on the direct procedure and DRGs and things. But it's been well shown in system level studies that IVUS and FFR usage saves money to a system. The problem is the individual doctor his costs are different based on these. So I think part of the limitation in adoption, in spite of the amazing data that's been generated over the last 25 years, and you were one of the pioneers in the IVUS data, has been this reimbursement issue. Luckily, we're in a practice style where we try to do what's best, and we've been able to fight those fights to continue to use. So in our group practice, we use IVUS in about 70% of our cases.
Yeah, I'm going to finish with a rhetorical question. You don't need to answer this. One of our colleagues in the audience says, many thanks, very interesting. A big question is, when is medical therapy can be considered optimal medical therapy? So we're going to go ahead and go with the next speaker. Dr. Traynor is going to introduce.
Thank you, Dr. Tuju. It gives me great pleasure to introduce my dear friend and colleague, Omar Dar. Dr. Dar is going to be speaking to us about left main disease, and CABG isn't the best choice. Omar has recently joined us from Yale University, where he was the surgical director at the Yale New Haven Bridgeport program. He has a ample experience in coronary artery disease care and aortic disease, and established a robust HOCM program, and been greatly involved in also the TAVR programs and establishing that program there. Omar was actually trained at Aga Khan University in Pakistan, and until he moved to Yale for his training and continued to stay there. And we're lucky to have him with us at Cleveland Clinic, Abu Dhabi. Omar, we're looking forward to your talk.
Good evening, everyone. Greetings from Abu Dhabi. My name is Omar Dar. I'm a cardiac surgeon here at Cleveland Clinic, Abu Dhabi, and I'll be talking to you about left main coronary artery disease and why I think coronary artery bypass surgery is still the best choice for this pathology. I have no disclosures to report, and I would like to review some basic tenets of left main coronary artery disease. We all agree that it tends to a very large area of the myocardium, and pathology in this area can lead to serious adverse health issues for the patient. The therapeutic options that exist in this day and age are optimal medical therapy, percutaneous coronary intervention, or coronary artery bypass surgery. Once the disease is advanced enough, the two real modalities that one can offer are PCI or CABG. PCI has the advantage of expedient recovery, but bypass, I feel, has the advantage of durability. And I think there's a lot to be said about that. So far, there have been 6 large trials which have addressed the issue in a randomized control fashion as to what modality is superior, PCI versus CABG. The mean follow-up is about 3 years. And it looks like from these early trials that low or intermediate complexity disease, PCI is non-inferior. These trials were conducted with the more advanced stents with the physiologic analysis of the coronary flow dynamics with contemporary PCI standards. But one thing that has been absolutely critical in all these trials and has emerged to be a dominant theme is the importance of a heart care team. The process of deciding how best to treat an individual with left main coronary artery stenosis remains a complex decision-making process, and a well-established, well-functioning heart care team is vital. So people who have stable angina or silent ischemia need revascularization. The consensus is that they have greater than 90% stenosis, something needs to be done right away. If they have less than 50% stenosis, then optimal medical therapy is the way to go. The folks who lie in between these two groups are better helped by either documented ischemia or if on physiologic investigation of their coronary anatomy, if their fractional flow reserve is less than 0.8. CABG is still a class 1 recommendation in this pathology if the surgical risk is low and the outcome is likely to be a good one. PCI remains a reasonable alternative, but it has to be guided by syntax score. And there's agreement that if the syntax score is low, then it's possibly a class 1 indication. For intermediate syntax score 2A, and for high syntax score, a class 3 indication. So ultimately, I cannot overemphasize the importance of a well-established, well-functioning heart care team comprising of a cardiologist who knows the patient well, a interventionalist who is technically gifted, and a cardiac surgeon who looks after coronary artery disease on a regular basis. Both US and European guidelines strongly advocate that this dialogue should occur prior to the management of left main coronary artery disease. So let's now review in totality the available data that we have of coronary artery disease and its management in PCI versus CABG. We've had a very interesting meta-analysis of the 5 major trials. This was published in the European Heart Journal in September of last year, and it takes into consideration the NOBLE trials, SYNTAX, EXCEL, PRECOMBAT, and BORDREAU. The important thing to note here is that SYNTAX is the only one with the 10-year follow-up. The others are relatively new. In this chart, you will notice the overall risk of death, and there was, although no statistical significance, and both arms did reasonably well. The risk of cardiac death, again, remains not too different in the two groups. Risk of stroke, as you would expect, favors a PCI in this outcome, a less invasive option in a population that is notorious to have concomitant carotid artery disease in addition to coronary artery disease is not a surprise, and prior trials have established this relationship as well. The risk of MI has equipoise in both arms, but the most important finding that was consistent in virtually all trials with all different kinds of stents, Taxus, Science, and that the risk of unplanned revascularization was substantially higher for PCI as compared to coronary artery bypass. So the durability is clearly on the side of surgery. And more importantly, I worry that the unplanned revascularization may be a euphemism for a acute coronary syndrome or another event that led to the discovery of need for revascularization. So let's quickly examine the SYNTAX trial. That really is the only meaningful trial that has been investigated for an extended period of time and gives us a better sense of the durability of PCI. And I'm going to quickly touch base on some very highlighted important issues. And in this trial, the use of a single arterial graft was superior to PCI with Taxus drug-eluting stent. The other important thing that clearly came out was that the largest benefit of bypass seems to be in patients with diabetes. And long-term results indicate that adverse clinical outcomes are lower for CABG as compared with PCI due to reduction in repeat revascularization, myocardial infarction, and myocardial infarction-related mortality. So I think in essence, it's important to remember that the patients with left main disease and low and intermediate syntax scores, lesser complexity, may do well with PCI, but people with high syntax scores are clearly doing better with bypass surgery. So I'm going to quickly present to you an angiogram of the patient that I operated on this week who had PCI to left main recently. And as you can see that there is substantial instant restenosis, and this is a pathology that is still difficult to address in this particular population. So in conclusion, I would submit to you that coronary artery bypass remains the gold standard for left main coronary artery disease. It remains a class 1 indications. Surgeons should make every effort to use multiple arterial conduits, especially in younger patients. Heart care team approach cannot be overemphasized. PCI is an acceptable alternative, provided that the syntax score is low or intermediate at best. Long-term data needs to be reviewed for the remainder of the trials that are out there and ongoing. But something that these trials have not addressed, and I think is very relevant, especially given the part of the world that I practice in, is the socioeconomic impact of offering PCI versus CABG. And surgery may be more cost-effective for both the patient and the healthcare delivery systems in the long run. Thank you very much.
Thank you, Dr. Amar, for a fantastic talk. Really brought up some great points. I'm still waiting on any questions from the audience, but maybe I can ask you a question from myself. So what if I'm doing a case in left main and I go ahead and stent it and I come and tell you, I talked to the patient and they refused surgery. I offered them both choices on the table and I did it ad hoc. What would be your thoughts on that kind of approach, which we see pretty commonly in our region?
I think it's important that we all remember to do a heart care team approach. And I think that's a critical part of the process. And to neglect that is really a disservice to your patients.
And where do you think patient's preference plays into this kind of consideration? So in terms of, as you're aware, I'm sure a lot of people don't, their first choice isn't always to get a bypass surgery or open surgery when it can be handled with stents. And how do you kind of discuss this when you talk to your patients?
That's a very good point. Unfortunately, I've yet to meet the patient who woke up one morning and felt like having a surgery or their chest open. But I think the devil is in the detail. It's so important to educate your patient appropriately so they make good choices. People still have surgery for cancer. People still have surgery for non-cardiac illnesses. So it's not as if surgery has gone out of vogue. So I think if enough data is presented to the patient that they can make a good educated decision, and particularly if they understand that even if they avoid surgery at that particular day and in time, they are looking at a surgery in the near future, particularly if they're a diabetic, I think they will make the right choice. And most people, the reason surgery carries a bad rep is the risk of discomfort, the risk of mortality and morbidity. But I think in good centers that can be mitigated.
Okay,
and I apologize, my video somehow is not working. I've tried to get on, but I apologize for that.
No worries whatsoever. Any other questions from the audience? Amar, just as a last question, when as being obviously a surgeon, is there any scenario where you see that patient with left main disease is best treated with percutaneous intervention?
That's actually an excellent question. I think there are patients where surgery should not be offered. So like everything else in life, and particularly in medicine, there are no absolutes. So people who've had substantial radiation exposure to their mediastinum, people who have significant comorbidities, they have a cancer that would limit their survival more than a year. These are all things that can be discussed in a proper heart care team scenario, and both sides need to be realistic as to what exactly is being offered. So I think in a patient who has long-term survival, is a young provider for a family, most likely a male in his 40s, And not only is it important to get him out of trouble on that particular hospitalization, but also to keep him out of trouble for several years and decades if possible. And I think I will submit to you that that is better done by surgery. And I think these trials, although have not shown statistical significance for survival, the trend clearly favors surgery and durability clearly favors surgery.
Just as a final question, now having worked in a couple countries in our current region, in the UAE and Pakistan, my thought is that there seems to be a little bit of a slower adoption of the heart team model in our regions in general. What's your thoughts on why that is so?
Actually, heart care team approach is still not well adopted in a lot of the different centers. And, you know, a lot of patients have this expectation that while they're on the table, quick decisions will be made and they will get a help right then and there. So this is not just true for third world countries or our part of the world, but also in the Western world, that heart care team approach is an afterthought. And and I cannot emphasize enough that it has to be a well-oiled machine, so that even if an event happens in the middle of the night, we can quickly assemble a heart care team and do the best thing for our patients. So if the more we do it, the better we get at it, the more we trust each other's opinion. And I think it's clearly the way to practice medicine in the future. I think the good thing that has come from the TAVR program is that it has educated us the value of a good heart care team. So I think any hospital that is doing that should replicate that model. So I think that has been an amazing learning experience for even surgeons who did not choose to like to take input from other people, that a heart care team approach clearly is beneficial for everybody.
And just a final brief question that came from the audience. What's the best option for acute coronary syndromes with left main disease? And how does that impact your decision-making?
I think that surgery can be offered. In fact, we do surgery on an emergent and urgent basis for left main disease. And you can do multi-arterial conduits for these patients. In fact, the angiogram that was in my presentation was a gentleman who was transferred to us from another outside facility with unstable angina and needed an emergency surgery. And we did use multiple arterial conduits. So I think if you have enough experience, that can be offered safely.
Great. Thank you so much, Omar. That was fantastic. We'll move on to the next speaker. So we'll get the slides up. Okay, it's my privilege to introduce our next speaker, Dr. Grant Reed. Dr. Reed is an interventional cardiologist at Cleveland Clinic main campus. He'll be talking to us today about left main disease. PCI is the best choice. Had the privilege of meeting Dr. Reed a couple of times, both at main campus and in Dubai at one of the meetings. He's a brilliant interventional cardiologist who is deeply involved with the structural heart team, does high-risk PCIs, TAVRs, involved with the mitral valve program as well. And he currently runs the STEMI program for the main campus and the entire Cleveland Clinic Foundation enterprise. So we'll go ahead and listen to hopefully an exciting talk by Dr. Reed.
Thanks very much for having me today. I'm Grant Reed. I'm an interventional cardiologist at Cleveland Clinic main campus. And I'm going to discuss left main disease. And the topic I was given is PCI is the best choice. And I think really it should be better phrased as, when is PCI the best choice? Because bypass grafting is most often a very good choice and has certain advantages, but PCI is a very good choice in many patients. So I'm going to move pretty quickly. Just to cover a lot of ground, but as we all know, left main coronary artery disease is very commonly encountered in diagnostic catheterization, and it's a very morbid condition. So this is something that needs to be treated when it's discovered, even in patients who are asymptomatic. And recent clinical trials suggest that PCI may have equivalent outcomes in certain, and actually most patients with left main coronary disease. It's all about patient selection. So the current US guidelines say that CABG is a class 1 recommendation for patients with left main coronary disease, but in in almost all circumstances, PCI is a class 2 recommendation. However, if patients are good candidates for CABG and not good candidates for PCI anatomically, then obviously CABG should be preferred. And that's kind of the US guidelines in a nutshell. The European guidelines actually give a PCI, a class 1 recommendation for patients that have a syntax score of less than 22. So that's different from the US guidelines, which is class 2 across the board, but in the European guidelines, a syntax of less than or equal to 22, meaning that's straightforward left main disease. It's not bifurcation. Usually that's proximal or ostial left main disease. It's a class 1 recommendation with strong evidence to support that recommendation. And the appropriate use criteria the United States used to really classify procedures as being appropriate or not. As you can see, CABG is appropriate across the board, whereas it's it may be appropriate in most cases, but honestly, the guidelines what we follow mostly. This just kind of echoes that. So, for the interest of time, we're going to discuss the clinical trials, but focus on the most contemporary ones when it comes to left main disease, including the Syntax trial, the observational studies from Syntax, as well as Noble and Excel. So Syntax, as we likely all appreciate, it's a large randomized controlled trial of patients randomized to PCI or CABG, and these patients, either had multivessel coronary disease or left main, for the purposes that we're going to be discussing. There was a pre-specified unprotected left main cohort of around 700 patients. And when you look at outcomes out to 5 years, if you look at all patients who had left main disease and underwent either PCI or CABG, overall outcomes were fairly equivalent, as you can see here. This is all patients regardless of syntax score. If you look at the different components of the composite endpoint, you can see here that there was a benefit towards CABG with regards to repeat revascularization. However, there may have been a benefit towards stroke with PCI. And you split it by syntax score, which you can find is that those patients that had a syntax score which is lower intermediate actually did equivalent in terms of the composite endpoint, whereas those patients that had an elevated syntax score of more than 33, obviously CABG was the better choice. And that's what you see here kind of in the hazard ratios as well. And really that was, the big benefit towards CABG was in those patients that needed repeat revascularization. So that's syntax, but that's a pre-specified analysis of a randomized controlled trial. So, when you look at the actual RCT data from some of the more contemporary studies, including Noble and Excel, you see a similar but slightly more nuanced picture. So Noble was a trial of around 1,200 patients with left main disease and up to 3 other coronary artery lesions randomized to a 3rd generation drug-eluting stent, but did not use syntax score for stratified patients, and actually included non-procedural MI in the definition of their composite endpoint. And what Noble found was that there was an increased risk of this composite death, non-procedural MI, repeat revasc, or stroke with PCI compared to CABG. However, that was driven mostly by this non-procedural MI piece. As you can see here, there was no difference in death. There may have been a trend towards a benefit in stroke towards CABG, but very low numbers of events. But again, this was driven mostly by repeat revascularization, which drove this MI component, which is again more of a periprocedural definition than anything. So those are the main takeaway messages from Noble. Again, any adverse event was increased with PCI, but again, this was due to repeat revasc and non-procedural, a slight trend towards non-procedural MI, but that was a different definition that was used compared to Excel. So Excel is really the largest trial which looked at left main disease. And this is probably the most contemporary trial. There is some controversy regarding the results. In Excel, it was a very heavily driven IVUS FFR study. So they really wanted to prove that this left main disease was clinically significant to the patient. And everyone Excel actually had lower intermediate syntax scores. So it did use it did use syntax to stratify. It actually included death, stroke, and MI, but not revascularization in the primary endpoint. And as you can see here in Excel, results published after 5 years, really no difference between this composite endpoint of death, stroke, or MI, between PCI and CABG. However, you can see that maybe there was a slight advantage early on towards PCI, but the hazards really aren't proportional. That the curves cross, here at about 2.5 years. So the key results here is that really there's no difference in composite death, MI, or stroke. There's maybe a trend towards less mortality with CABG, and really no difference in MI or stroke. There is less ischemia-driven revasc with CABG, but again, there's really, I think the message is that outcomes are overall pretty similar. There are some limitations, however, is that, Excel, we have 5-year follow-up, so that's not so much limitation anymore, but revascularization was included from the primary endpoint. That actually was the focus of the 5-year paper, as you can see here in the bottom right-hand corner of the screen. However, that's not the primary endpoint. And also, it wasn't really powered for components of the composite. So there was some controversy regarding the results, as there was a trend towards improved mortality with CABG, there was some debate about why that was. It turns out that when you look at cardiovascular death, there really is no difference, but that was adjudicated post hoc. And there's also a little bit of concern towards periprocedural MI definition that was used, as that seemed to actually, favor PCI early, as some of the patients undergoing CABG were being labeled as having MIs. So Excel, I think, is, for, some of the controversy is actually still a very good trial. There's some good lessons to learn from it. And I think it fits in really well with our overall clinical picture of the knowledge base that we have right now. Some of the sub-studies here is that there are really no differences in gender, and no differences depending on whether or not this was an osteo or distal bifurcation in Excel. However, this really just echoed the overall results of the study. So this is just a very quick table comparing the differences between Excel and Noble and why they had slightly different results. I think the key things here are that Excel had syntax score criteria, and it actually did not include revascularization in its primary endpoint, but it did include periprocedural MI, whereas Noble didn't. Those were all MIs which were not considered periprocedural by the definitions that we use today. Again, in Excel and Noble, the vast majority of them, had IVUS guided contemporary, strategy used. I think overall, they're both very good trials to inform our decision making. So I'm going to finish out with 2 quick cases of when we think it may be appropriate to do left main PCI or send someone to CABG. So this is a case of a 74-year-old woman with an end STEMI, and overall has some significant comorbidities, including some pulmonary hypertension. And as you can see here, has a very osteo left main coronary stenosis. So how would you treat this patient? Would you send him to PCI or CABG, knowing that their overall syntax score is actually low, right? This is a patient that would be very well suited for PCI, and in the US guidelines would fit here. In the European guidelines would actually be a class 1 recommendation. So this would be a good candidate for PCI. Whereas in this case, as you can appreciate, this is the end result here, as you can see. The second case here I'll highlight is a 69-year-old patient who's a diabetic and doesn't have any other major comorbidities and has distal left main disease with, as you can see here, a large circumflex and LAD. So how would you treat this patient, PCI or CABG? And I think most patients in this case would be referred to CABG because of this class 3, which is, a class 3 recommendation in the United States, which is if you have unfavorable anatomy for PCI, you're a good candidate for CABG. You would be preferred. As you can see here, CABG is the result. So the take-home points is that CABG is generally preferred over PCI for left main disease, but in patients that have a low syntax score and relatively straightforward anatomy, PCI is a class 1 recommendation in Europe and can be considered in the United States. It is a reasonable alternative after heart team discussion in selected patients, such as low syntax score, unstable ACS, and patients that have many comorbidities, because there's really no difference in mortality between PCI and CABG in the studies that we have to date. And, the main benefit of CABG is that there'll be need for less repeat procedures in the future, potentially. However, that's a trade-off that many patients are willing to make. So I know there's a lot of information in a short period of time. I really thank you very much for your time, and feel free to reach out with any questions. Thanks.
Thank you, Grant. That was fantastic. I really appreciated that talk. Let me start with a question while I wait for some questions from the audience. But in your practice, so you have a patient with a stable outpatient comes to you in clinic, and you do a cath and you find left main disease. What's your walk us through your kind of process, and what do you exactly do? How do you make the decision on therapy?
Great. Yeah, thanks a lot again. And thanks for bearing with me when I raced through a whole lot of content in a short period of time. I don't think I've spoken quicker in my entire life. It's a complex topic. This is something that, all of us encounter as interventional cardiologists. I think when I see someone with left main disease, I think importantly, even patients that have ambiguous anatomy, it's very important to define if that patient really does have left main disease. If you're wondering about it, you should IVUS, and you should define it, because it's a very serious problem, which is easy to miss. So one is have a high index of suspicion. Two is in someone that has acute coronary syndrome, if they have a STEMI with left main disease, most interventional cardiologists are gonna do PCI for that right away, right? And that's because deferring revascularization for CABG carries risk. Some patients you may be able to stabilize with balloon angioplasty and a balloon pump if needed, and then refer them to CABG. But oftentimes patients are very sick, and we get worried that just doing balloon angioplasty is not going to give a good result, or maybe carry some risk. So in patients that have STEMI, unstable angina that can be stabilized, then yeah, I think CABG is very reasonable. But in the heat of the moment, someone that has a STEMI with left main disease, that is, I think, a situation that I do not hesitate to offer PCI. In patients with stable coronary disease or left main disease, I think Dr. Dar said it perfectly, is that the heart team approach is of the utmost importance. And often what we'll do is we'll pause, we'll have a good conversation with the surgeon, and determine a strategy. If the syntax score is low, and the patient has significant comorbidities, sometimes it's best served by just a phone call to the surgeon. And often the strategy is well defined and laid out even before we start. I try to make sure that we have a plan in place and contingencies, and we know what we're going to do depending on what we find ahead of time. And I really I task my fellows with, before the case, what if this patient has left main disease? What if the patient has this and that? Are they diabetic? Or what's their ejection fraction? What's their what are their overall risk factors, so that we can make a decision quickly. But a lot of that comes down to advanced planning. So you just try to prepare as best as you can ahead of time. If you can pause, you do. And in situations where a patient's unstable, you should know the left main PCI is a very good option. There may be a higher risk for MI down the road from non-protected arteries. The patient, arteries that have not been PCI'd, that bypass may do a better job of protecting from that spontaneous MI. But the risk of left main PCI failing is maybe around 2 to 3% per year in contemporary studies. Bifurcation lesions may be a little higher, so it's still a very good option in a lot of patients.
Great. And Grant, what would you say? So let's say I'm thinking about starting a left main program and trying to take on these cases. What are the absolute must-dos or must-haves as an interventionalist to really achieve results that, like you showed in Excel and Noble, that kind of can almost mimic surgery?
Yeah, that's a great question. So one is, I think the message here is that in patients that are good candidates for CABG and are have stable coronary disease, we really should strongly consider bypassing those patients, not just the diabetics, but all patients. And that's kind of the message that we're getting. When starting a left main PCI program, there's really a component of your overall program to address revascularization solutions in patients. So you need to have 1 or 2 interventional cardiologists that are committed and devoted and able to do these high-risk cases. Right, the majority of patients that we do for left main PCI are patients that aren't good surgical candidates, right? And that's the bottom line, is that we're not going around and most of us are, I think guideline driven and not throwing in stents in young patients that have good bypass option, but these are patients that have significant coronary disease. A lot of what I do is in patients with severe aortic valve stenosis that are high surgical risk, and they're referred to me for TAVR, and we uncover, very bad left main disease in the process, and that gets to be a challenging situation to treat, and they're high risk patients that we do our best with PCI. So having that technical ability is very important, both from an interventional standpoint and a surgical standpoint. Having surgeon buy-in and having interventional buy-in, having a good relationship. A lot of this comes down to relationships with colleagues and relationships with patients. Because in my opinion, there are very few areas of cardiology and medicine that are more collaborative than this, and then they should be. Otherwise, you're going to get into a situation where you're asking a colleague for help, and if they haven't bought into the strategy, then it can strain relationships. So you have to be very considerate of your colleagues and consider the patient. And as Dr. Dar had said, sometimes, when a patient's on the table and you say, hey, do you want PCI or CABG? They're going to say, oh, I don't want to come back. I want to have PCI. But you have to be, I think, aware and smart and have the courage to say, okay, we're going to pause. I know this is what you really want, but we're going to have a conversation. And sometimes I think at least, not telling the patient this is what's best. If you have the conversation ahead of time, that's great. But patients on the table, they're under sedation. A lot of them just want to get it done. So pausing is very good. And I think having a very well thought out heart team approach ahead of time will help facilitate that conversation. So.
Thank you. Excellent. Thank you so much, Grant. I think we'll move on. Dr. Tuju, you're on for the next.
Mahmoud, the next speaker is you again, and the title is ST elevation myocardial infarction with multivessel disease, complete revascularization of non-culprit lesions. This is a hot topic for the last few years, and then we're looking forward for your talk.
And for having me today. This talk today now will be about STEMI with multivessel disease. It's complete revascularization of non-culprit vessels, and I think this is an area that's really changed in the last 10 years, and so I think it's important to address. So this is a case. This is a 64-year-old male presented with an acute anterior STEMI, occlusion of the mid-LAD, as you can see there. No significant disease in the left circumflex, just a lot of plaque. His RCA showed an 80-90% focal mid lesion. So we carried out PCI of the LAD, successfully intervened on, but there's still some residual TIMI 2 to 3 flow after intervention. So the question arises, what should we do with the RCA? Now, up until 2012 guidelines, it was class 3 indication to fix non-culprit vessels in the setting of STEMI. However, in the last 10 years, there have been multiple trials looking at PCI versus medical therapy in this group of patients. And between these trials, they totaled over 7,000 patients and kind of looking at various strategies in approaching them. Now, we can kind of group it in this kind of setting. So if we have a multivessel disease STEMI patient, the traditional approach was the green here on the right, conservative management, revas based on ischemia and symptoms. On the opposite pole, you have the aggressive multivessel PCI acutely during the initial STEMI. And again, you could do the revascularization either based on angio or based on FFR, or kind of in between where you use a staged approach and with staging the vessels either based on angiography or FFR. So the first major trial that was published, the randomized trial looking at this, was the PRIME trial. It was a small trial, but it really kind of shook up the field. And it was used complete revascularization at the time of the STEMI. So at the same procedural time, showed that PCI of the non-culprit vessels dramatically reduced MACE with a 65% reduction in MACE. And that persisted out to 3 years. This was followed up by the culprit trial a couple of years later, and it allowed a little bit more flexibility where it could be done either in the index PCI or staged. And it showed that this benefit is demonstrated early and sustained. So it starts very early, so the curves separate, and out at 30 days, we see a significant reduction of over 50% in events. This was followed by the Compare Acute trial, which added the extra wrinkle of using FFR to assess the non-culprit lesions. So in this trial, they used a 2-to-1 randomization, one group where they did the complete with acute FFR guided complete revascularization. And the other group of patients, they treated only the infarct related only, but they did do blinded FFR on the non-infarct related artery vessels. And when they look at the outcomes, again, 65% reduction in events using the complete revascularization strategy, and showing that these non-culprit lesions in STEMI patients are more apt to have issues down the line and different than the stable CAD patients. Interestingly, I like this because it shows what are the rates of the FFR positivity, and they're about half the patients that they looked into FFRing. About 50% had were positive and 50% were negative, and I think that tells you about how good we are at assessing these borderline lesions. That FFR is a very useful tool in differentiating. This shows their composite endpoint of the MACE, and it was, it did not reach statistical significance with mortality, primarily driven by reductions in MI and repeat revascularizations. So then we get to the largest of the trials, and I think the most definitive of these trials was the complete trial. And this used a completely only staged revascularization as the strategy. So for the complete revascularization, so everything was taken care of culprit. Patients were randomized after the successful culprit PCI revascularization and either into complete revascularization or only medical therapy for these arms. And they use a combination of FFR for lesions that are 50 to 70% and direct stenting for those over 70%. And in this large, big trial, we again showed a dramatic reduction, about 25% in death or MI, just so looking at hard endpoints, reduce with a number needed to treat of 37 to reduce events. If we added ischemia-driven revascularization, that number increased to 50% reduction with a number needed to treat of 13 to prevent one event out to 5 years. Now, this was a larger trial, more flexible, so they allowed the staged PCI either during the same hospitalization or after, and really wasn't associated with any difference. So timing could be done at the practice style of the practice, whether it's easier to do it during the same or later on. And if we look at subgroup analysis, there's no major difference except for an interaction with the more severe lesions. So when you had lesions that were more severe, over 80%, tended to have more benefit than those that were in the intermediate range. So what about if your patient presents with shock? So what do we do with shock? So one of the rationales could be that a patient in more severe shock, you're more likely to open up the other vessels to improve blood flow to try to get them better. And that's what the culprit shock, which is a very nicely done trial, was done to address. Enrolls over 700 patients. Not all STEMI, so I'll say only about 60% of them were STEMI, but the same kind of concept. 52% of them had needed resuscitation, so they're pretty sick patients. 80% of them were intubated. Almost a third of them required mechanical circulatory support. So when we look at it, so this is a trial looking at all-cause mortality or renal replacement therapy, need for dialysis. And when we look at it, so immediate multivisceral PCI had a 55% event rate out to 30 days. And if we just did the culprit, only 45%. So patients did much, much worse. Number needed to treat was 10 to have one event if you did multivisceral PCI at the time of the initial event. So how do I put this all together and what's kind of my STEMI approach? So if I have a patient presents with an acute STEMI, if they have first, do they have multivessel disease? No, then we're done. Yes, then are they in cardiogenic shock? If they're in shock, then we're going to hold off, give them hemodynamic support, whatever is available, balloon pump, Impella, et cetera, as indicated. If not in shock, then the question is, was the STEMI PCI uncomplicated? I include even the presence of reduced flow as being somewhat complicated, and if there's some microvascular dysfunction, I'll include that. If it has some sort of complication at all, definitely hold off and stage. Most of the time in our practice, we'll do them in the same hospitalization. If there's any issue of renal dysfunction or otherwise, then we'll bring them back after a couple of weeks and let them recover. If it is uncomplicated, then the question is FFR available? For us, it is available, and I think that's a strategy that should be done. If it is yes, then we use FFR guided PCI. For intermediate lesions, anything less than 80%, we'll use a FFR kind of make a decision on. If no, then I think you need to focus on the really severe lesions. I think the trials kind of show that we need to up it maybe closer to 80% for lesions that we should be treating. So back to our patient. He was brought back to the lab a week later. PCI was RCA is done, and he's doing well. Thank you.
Well, thank you very much, Mahmoud. Great talk. And then this is an interesting field for sure. And then you summarized very nicely at the end. Let me just ask you, now we're using hemodynamic support, although the data backing that up is not as clear as we would like it to be. But tell me, in a shock patient, if you introduce the hemodynamic support earlier, is there any evidence that will tell us that maybe we should change our strategy and be more aggressive in revascularization at that session? And also, can you also speculate a little bit, what are the mechanisms of harming patients when you do the multivessel intervention in STEMI with shock?
I think it's twofold. First of all, this has been a big debate whether we should start the support before the intervention or intervention and then the support. I think there's been some data out of the Detroit groups suggesting that maybe we should be doing more support before the intervention. It kind of varies and depends on the time in terms of my personal practice, what I do. If the patient's very severe shock and unresponsive and resuscitated, I usually will put in hemodynamic support off the bat. And most commonly balloon pump, and that's the easiest to get quickly. But otherwise, if they're borderline, I'll try to get the vessel open up quickly and then put the support afterwards. In terms of the worsening, I think a lot of it is that the hemodynamic effect is from the main vessel, and so taking prolonged time, opening up other vessels that were stable and making them ischemic at a time, territories at a time when the patient's already not doing well, may lead to that. And of course, you need a lot more contrast when you're doing it. So the patient's already in shock, you're giving them more contrast to kind of fix these other vessels. I think that leads to some of that instability. At least that's how I view it.
A question from one of the colleagues online. How do you reconcile complete revascularization of other stable lesions in stimulation myocardial infarction? Seems to contradict the ischemia trials, which pleads for a more conservative approach for stable lesions. Is it because they already had an ACS event? I think it's an interesting question.
Yeah, I think that's a fundamental question, because we've kind of, I think in the last 5 to 10 years, really hit a clear dichotomy between ACS patients and stable patients, and they're completely different phenotypes and different natural histories and different disease courses. So I think patients with stable disease, we have clear evidence that those lesions are stable and their risk of events are extremely low, and fixing them to reduce events doesn't work. But patients with ACS in one territory, obviously based on this data, seems that the other lesions are much more at risk for rupture. So they have a phenotype that predilects them to having further events, and those lesions and those vessels, fixing them seems to have a clear reduction in events in the future.
I think that's a terrific point, that there's almost like two different disease entities, stable angina and unstable status. first the pathologist, Vermani did a lot of work with that. Then with intravascular ultrasound and later on with OCT, we saw over and over and over, when somebody comes with an acute coronary syndrome, there are actually many more than one ruptured plaque, many more than one ruptured and thrombus superimposed plaque, even though they may not be all causing the trouble. So I think that the instability is a more systemic problem of the entire coronary tree with the inflammation and so forth. So that's a critical distinction, I think, but nevertheless, the question was very good. And then, that I think that your summary slides, I liked it, and I'm not the only one that liked it. You got some more comments about that it's a helpful flowchart. Thank you very much, Mahmoud. And now I'm going to go ahead and introduce one of my very old friends. Dr. Michael Linkoff is a 30-plus year friend of mine, and a very dear colleague and a very, very close collaborator. He is a legend in the area of antithrombotic therapy. It literally goes back 30 years, his work. He wrote seminal papers, published books, and mentored countless fellows. We all learned from him and his work. And then he is the vice chair of for research for the entire institution, and chairs the clinical research enterprise, which is a huge enterprise. So I'm very proud to and grateful to have Mike to devote his Sunday morning, precious Sunday, for somebody that's working so hard. So Michael, thank you and welcome. And please go ahead with your talk titled Antithrombotic Therapy in PCI. When we might drop the aspirin. Very, very timely question. Thank you.
I'm Michael Linkoff, an interventional cardiologist at the Cleveland Clinic, and I'm going to review the evidence for when we might drop the aspirin with antithrombotic therapy in PCI. My conflicts of interest relate to my role as the director of our coordinating center, the C5 research. As a case example, I present a 68-year-old woman who presents with chest pain for 90 minutes. She has a past medical history of hypertension, diabetes, paroxysmal atrial fibrillation, and tobacco use. Her examination on presentation was benign and her vital signs were stable. Her home medications included apixaban for the atrial fibrillation, lisinopril, and metformin. And her electrocardiogram showed a normal sinus rhythm with ST segment elevations in leads 2, 3, and AVF, with depressions in leads B4 through B6. In the emergency room, she was treated with aspirin, 325 milligrams chewed, a bolus of clopidogrel, and heparin of 5,000 units intravenously. Coronary angiography was performed emergently, showing mild left coronary system disease with a hazy 100% occlusion of the mid-right coronary artery with minimal distal flow. She was treated by PCI with a drug-eluting stent to the mid-right coronary artery. Follow-up echocardiography during the hospitalization showed moderate inferior hypokinesia with an ejection fraction overall preserved of about 45%. So this case illustrates a common dilemma that we're faced with the convergence of atrial fibrillation and the need for oral anticoagulation, and the subsequent need for antiplatelet therapy because of placement of a coronary stent. And we don't expect the anticoagulants to be protective alone against the risk of stent thrombosis. We certainly know that combinations of antithrombotics do increase the risk of bleeding. Perhaps some of the best data we have for this is from a large Danish registry of over 82,000 patients after atrial fibrillation hospitalization. And they showed that the risk of bleeding was increased with every type of combination therapy used, including combinations of antiplatelet agents alone. But interestingly, the protection of antiplatelet agents against the risk of stroke, the main indication, of course, for anticoagulation with atrial fibrillation, was inferior to that of warfarin. And it was, so the triple therapy or the combination of warfarin plus clopidogrel in this study, which do seem to be predictive, or are associated with an increased risk of bleeding, at least in this retrospective analysis. So this dilemma has led to a number of trials, fortunately trials that have become increasingly definitive to address this issue of what is the best anticoagulant regimen in patients who have atrial fibrillation and undergo PCI. The first foray into this was the WOST study, in which patients who underwent PCI who were treated with warfarin, 503 patients, had the indication for warfarin, and then were randomized to either double or triple therapy. Double therapy consisting of clopidogrel alone, and triple therapy with clopidogrel and aspirin, so an antiplatelet along with the warfarin. And they showed, perhaps not surprisingly, that the double therapy, that is holding, not using the aspirin, was associated with a substantial reduction in the bleeding risk, almost a 70% reduction in bleeding risk. And they also showed, perhaps somewhat surprisingly, that the protection against ischemic events appeared to be better, in this case significantly, with the double as compared to the triple therapy. Now, I'll emphasize this was a relatively small study, 500 patients, and so the power to detect a possible adverse effect in terms of ischemic events was not great in this study. Subsequently, two larger studies were performed, each of about 3,000 patients. The first with rivaroxaban in the so-called Pioneer study. This had a complex design of 3 different groups, but basically the reference group was the so-called group 3 with the vitamin K antagonist plus dual antiplatelet therapy, compared to group 2 where instead of vitamin K, they used a very low dose of rivaroxaban, and then group 1, which used a low dose of rivaroxaban plus the P2Y12 inhibitor only, not aspirin. So testing the use of single antiplatelet therapy, and showed in this study that bleeding was reduced by either of the 2 arms compared to vitamin K and DAPT, vitamin K antagonist and DAPT. So bleeding was reduced by both approaches, and ischemic events were about the same for all of these different groups. Again, with about 3,000 patients. With about 3,700 patients, the REDUAL PCI trial also compared to warfarin triple therapy, that is dual antiplatelet therapy plus warfarin. In this case, using dabigatran, either the low 110 milligram dose or the 150 milligram dose approved in the United States, and showed that bleeding was reduced with both of these single antiplatelet therapy arms, with what again appeared to be no difference in ischemic complications. Yet neither of these really used the factorial design to independently investigate aspirin versus no aspirin or warfarin versus a NOAC. And that was the intention and the design of the Augustus trial. This was a large trial of 4,600 patients which used a true factorial design, randomizing patients to apixaban or vitamin K antagonist begun immediately after their intervention, and then sub-randomized to aspirin or placebo, with the primary outcome being the bleeding events, and showed that bleeding was reduced by the holding aspirin, placebo versus aspirin, that is single antiplatelet therapy, and also reduced by apixaban as compared to vitamin K antagonist, whereas the ischemic events were similar to all of these, in all of these arms. And the risk of stroke, which is of course the driving indication for the anticoagulant, was lower with apixaban compared to vitamin K antagonist, again echoing the results of some of the original trials of apixaban. The question of whether or not the choice of P2Y12 agent influenced the outcome in these trials is difficult since most of the trials use predominantly clopidogrel. But we do have data, particularly from the Augustus trial, with regard to bleeding. And although prasugrel and ticagrelor were associated with higher bleeding rates overall than clopidogrel, the advantage of not using aspirin in reducing bleeding and the advantage of using apixaban as compared to vitamin K antagonists was preserved for each of these P2Y12 antagonists. So the results of these studies raised an important question, perhaps outside of the setting of atrial fibrillation. Is there an indication to modify our dual antiplatelet therapy? As you know, there's currently an algorithm based upon bleeding risk and based upon indication of how long you continue the P2Y12. But the question is, should we instead be looking at how long we should continue the aspirin instead of stopping the P2Y12 inhibitor? This was addressed with a couple of small trials which were non-definitive in any way, but a large global leaders trial assessed the use of ticagrelor or clopidogrel for a period of 1 year as compared to, with aspirin, as compared to ticagrelor alone with aspirin only used for 1 month in patients undergoing PCI. Now, this was a large trial. It had a lot of patients who did not finish their therapies for various reasons, and it was not routinely adjudicated. And so the study results were somewhat neutral. That is, there was no difference in mortality, nor was there a difference in bleeding with either of these two approaches, so showing no clear advantage of one over the other. The definitive study was the Twilight trial, a well-conducted study in which they assessed after 3 months patients who were high risk undergoing PCI, whether or not dropping the aspirin from that point with ticagrelor therapy as the underlying would be helpful. And so the goal was to give a short course of dual antiplatelet therapy to minimize the state-related thrombotic events, and then testing a monotherapy of ticagrelor alone versus dual antiplatelet therapy for the follow-up 12-month period. They did indeed enroll high-risk patients, patients with acute coronary syndrome, patients with high-risk coronary anatomy. With the 3-month period, some were excluded from actual randomization because they were not adherent to DAPT or they had an intercurrent ischemic or bleeding event. And then they were randomized. So the randomization point started at 3 months, and the results were quite dramatic and quite convincing. The bleeding risk was markedly reduced by ticagrelor therapy alone as compared to ticagrelor plus aspirin, and ischemic events were exactly the same. So there was no advantage to dual antiplatelet therapy after the first 3 months with patients who were treated with ticagrelor as their underlying therapy. So the question of when we can move beyond aspirin, certainly in the setting where there's an indication for oral anticoagulation, such as atrial fibrillation or DVT, it is very clear that the use of a direct oral anticoagulant, apixaban, rivaroxaban, or dabigatran, without aspirin is indicated from the time of the PCI onward. But following conventional PCI, and this is outside the setting of oral anticoagulant, of course, it's an individualized risk-based decision. You can base it on the DAPT score in terms of how long you want to treat with dual antiplatelet therapy. But after 3 months, even in high-risk patients, you can consider stopping the aspirin, especially if ticagrelor is used. Thank you very much for your interest.
Mike, thank you very much for a wonderful and very richly illustrated talk. So nice to see you. I want to ask you before going to the audience's questions and comments, I want to ask you when will you be comfortable to give just one of these new oral anticoagulants in patients with atrial fibrillation and history of PCI, or should we always continue with an antiplatelet as an adjunct therapy?
That's a very good question, and obviously comes up a lot. My tendency is to continue with an antiplatelet therapy indefinitely. I think that whenever there's been a stent, as we know, patients are somewhat prone to there is the possibility of very late stent thromboses. And so I would step it down if they're on ticagrelor or prasugrel to clopidogrel over the long term, but I would continue. Now, there's some situations where in patients high risk for bleeding, what you've got to remember is if they go off the if you've decided to not treat them with any antiplatelet agent, based on what you hope is some protective effect of the anticoagulant itself, there are many situations in life where they have to go off their anticoagulant, and they've got to know to restart aspirin or something if that happens, if they're going to get a colonoscopy or something like that. So you don't want to miss the situation where they end up on nothing. But in general, I don't think we have any data to support that an anticoagulant alone can protect a stent.
Another question that I have that we face in this part of the world, maybe a little more than the US, about this doing genetic testing and then see if antiplatelets one or the other is better suited. Do you use that at all? And what is your current thinking about that?
Yeah, I do not. And I think, the position papers of the ACC and others still say that genetic testing really has no proven role. No trial has really shown that you can guide therapy based on the genetic testing. And so I think that, I don't see a role for it. And what I will do sometime, if cutting back, is do actual platelet reactivity testing. Particularly in patients who if we're stopping the dual outside the setting of anticoagulation, but we're considering stopping aspirin, we just want them on clopidogrel after a year or so because they've got GI bleeding or whatever, may want to check to make sure they're actually responsive to clopidogrel before using that as primary therapy. That is not an issue, of course, with ticagrelor, for which there is no resistance, and that's where the big data for the trial is. But occasionally I'll use it to be certain that I'm treating them with an agent that actually works.
I have two questions. One is there an indication that you use triple therapy, and for how long?
So the trials actually did the randomization fairly early on, almost immediately after, PCI in Augustus, and within, I think it was 96 hours in the longest of them. So, the trial data is not giving a substantial period of triple therapy. That having been said, with STEMIs, I do try to treat with triple therapy for at least 2 weeks and sometimes, up to a month. And I guess you could say a very hot, unstable angina, but that's really not based on data. That's just based on, the lack of data in that highest risk group of patients.
And the last question is, how long triple therapy is indicated do you recommend in those patients who receive fibrinolytic therapy?
Oh, instead of a stent, you mean? Do you think that
yes.
question means instead of a stent? So that's a very interesting question. I haven't really thought of that. Obviously, you'd have to wait. You can use clopidogrel right away. You can use ticagrelor if you wait several hours. I guess I would probably take the same approach. That is, I would, we know the bleeding risk is so much higher with triple therapy. We haven't thought about it a lot because we don't use much fibrinolytic therapy, but it's a very good point to think through. The bleeding risk is clearly high with triple therapy. I think if double therapy is clearly protective for a stent, it should be protective for the post-fibrinolytic setting as well. So I follow basically the same guidelines.
Michael, thank you very much indeed.
It's my pleasure.
Wonderful to have you, and thank you for devoting your Sunday morning to us.
Thank you for having me join.
Thank you. All right, our last but not the least speaker is Jay Khatri. Jay also is an old friend from main campus, Cleveland Clinic, Ohio. He really brought definitely new breath, new energy, and innovation in chronic total occlusion CTO intervention, and he clearly exemplifies that chronic total occlusion intervention is a subspecialty on its own. His title is there still a role for interventional treatment for CTOs? Jay, thank you very much for devoting your Sunday morning to us, and it's a great pleasure and privilege to have you in our meeting. Go ahead.
Hello, my name is Jay Khatri. I'm Director of Complex Coronary Intervention at Cleveland Clinic. Today I'm going to talk to you about coronary chronic total occlusion. Is there a role for interventional treatment? These are my disclosures. The objectives of the talk today is to define what a CTO is and the prevalence of CTO. We'll go through the clinical significance for a patient having a CTO and the benefits of CTO coronary intervention. And finally, we'll go through some of the strategies and algorithm for treatment. The best way to understand patients who have CTO is that they're just a smaller subset of patients suffering ischemic burden from incomplete revascularization. And many of the data and evidence that we use to support treatment of patients with incomplete revascularization, they all apply to patients with CTO. The easiest way to understand this is through a clinical vignette. This is a true story of a patient of mine. He's a 55-year-old male avid runner with declining exercise tolerance. He's already on a statin for hyperlipidemia and has a history of coronary artery disease in the family. His exam was unremarkable. His ECG did show a left bundle branch block. He was sent for a nuclear stress test, which shows this inferior and lateral ischemia, which supports his symptoms, and was referred appropriately for angiography. Now, if the patient had this angiogram of the right coronary artery, I think it would be pretty straightforward in terms of what we should do. Take care of the right coronary artery. I don't think there'd be any debate anywhere in the world in terms of the best treatment strategy here in the scenario that I presented. Now, if the patient had borderline disease, for example, borderline disease in the crux of the RCA and some borderline disease in the circumflex, what do you do here? So here, I think that most people would agree that doing a hemodynamic assessment is the best way to determine. So for this example, perhaps treating the circumflex would be more clinically relevant. The problem is that we don't know what to do with patients. So this is FAME data supporting using hemodynamic assessment in hemodynamically borderline lesions and showing the benefit of medical or PCI versus medical therapy in hemodynamically significant lesions. The problem is this one. This is what my patient had, a total occlusion of the right coronary artery, which is collateralized to the left side. What do you do with this patient with the same clinical scenario? If he had multivessel disease, certainly you would tell our surgeon to bypass the right coronary artery. But why is it that in many parts of the world, many parts of our country, this patient would be told medical therapy for this single vessel right coronary artery disease instead of revascularization? The biggest issues are that the data that we have is incomplete. Most of it's observational. There's very limited randomized clinical trial data. But what we do know is that we can achieve symptomatic relief, we can improve LV function, we can help to better tolerate a future acute coronary syndrome, and that failed CTO PCI is associated with higher MACE rates. There's an ongoing controversy in terms of the relative value versus risk. It's still only a two-way indication in intersocietal guidelines, and there's certainly variability in terms of local expertise leading to medical therapy of many patients with CTO. Let's dive into what it is that informs us to take care of these patients. So we know from classical data from Dr. Werner that all patients with CTO have a positive FFR once you cross the lesion. So all these patients are ischemic. And this is irrespective of the size and quality of the collaterals that are pretending this area. And we also know that there's a threshold where there's probably a clinical benefit for revascularization. And this comes from data from the COURAGE nuclear substudy, which indicate that patients with significant ischemic burden by myocardial perfusion imaging likely have better clinical outcomes with revascularization versus medical therapy. The threshold that we use in the CTO world is around 12.5% of myocardium being ischemic. We know from prospective data that patients who present for whatever reason for coronary angiography, that if they have a concomitant CTO, that their overall prognosis is worse, and that treating the CTO can improve their overall prognosis. We also have seen that in patients presenting with STEMI and acute coronary syndrome, that a concomitant CTO portends a worse prognosis, both in the short term as well as in the long term. What happens when you treat a CTO? So the Open CTO Registry, which is a large prospective adjudicated trial done in the United States, that 30-day clinical outcomes show an improvement in quality of life and angina burden scores after successful CTO PCI. Who do you treat? So we know from data looking at viability and ischemia by MRI that patients with significant amount of ischemia and viability, they tend to do much better. So if you see here with this ischemia and viability by MRI, these patients do much better clinically in terms of symptoms as well as their cardiac function after revascularization. This is also borne true with nuclear studies. So this is a combination of PET for ischemia and MRI for viability, showing improvement in LV function and symptom relief in patients with CTO PCI. What about randomized clinical trial data? So the EXPLORE trial was a small trial done recently looking at patients who presented with STEMI and concomitant CTO and looking at MRI improvement in LV function after CTO PCI versus medical therapy. And in this trial, there was no clinical benefit seen. In a similar trial called the Revasc trial, patients were randomized to medical therapy versus CTO intervention with MRI assessment of pre and post LV function. The biggest problem with this trial is that the baseline EF in both arms was around 50%, and ischemia and viability were not really assessed, so somewhat of a difficult to understand trial. The Euro CTO randomized clinical trial randomized patients to medical therapy versus CTO intervention and did show improvements in quality of life and angina burden indicators in patients with successful CTO intervention. This is in contrast to the Decision CTO trial, which is a little bit of a larger trial, 834 patients across Asia, which looked at the composite of all-cause death, MI, stroke, and need for repeat revascularization, where they did not show a difference in medical therapy versus CTO intervention. Now, the big criticism of this trial is that before randomization, all patients had multivessel PCI, their patent vessels, so it's really hard to know exactly what to make of this trial. There are ongoing trials that are enrolling currently and that we'll need to stay tuned for to understand a little bit more about the clinical benefits of CTO intervention. That being said, where do you send patients if you decide they do need CTO intervention? And I think that the answer is you need to send them to high volume centers where we can achieve rates of success around 85 to 90%. What constitutes a high volume expert operator? Perhaps 200 cases of overall experience and 50 cases per year. We know that in high volume centers that do lots of CTOs, as their procedural success goes up, their risk of complication also goes up. And this is from these advanced crossing strategies. So this is subintimal dissection reentry using a stingray balloon. This is retrograde crossing through an epicardial collateral. This is using multiple entry points and intravascular imaging to avoid shaving off side branches. But that being said, all of these advanced strategies that are associated with a higher risk of complications and unique complications of CTO intervention that are not seen in other types of PCI, like collateral trauma, donor artery trauma, gear entrapment, radiation skin injury. In open CTO, which I mentioned earlier, the overall mortality rate was around 1% with an 86% rate of success, and that peri-procedural complications were associated with long-term decline in health quality scores. Let's put it in perspective. So if you put the open CTO patients into the SCDR or STS risk assessment tools, you can see that the observed mortality was somewhere in between at around 1%. And then if you compare open CTO mortality versus vein graft intervention mortality, they're pretty similar. So this is something that's done all over the world all the time without much pause, and yet CTO PCI probably has a lower risk of mortality. The biggest risk of complication comes from advanced crossing strategies, in particular retrograde CTO crossing. And that's led to a great deal of interest, at least at our institution, in trying to promote integrated crossing strategies, particularly novice operators using new guide wire technology. That being said, with all of these advances, if you look historically, the overall attempt rates were quite low in the US at around 5%, and overall success rates around 60%. This is from 2009 to 2013. And more contemporary data, you can see from 2010 to 2017, it's pretty flat at around 60% success and overall volume at less than 5%. So there's still a lot of room to grow in terms of training physicians to do this procedure. That being said, in expert hands, we know that there is some discretion that needs to be employed. We know that now from recent data that optimal PCI and CTO intervention has both a cost advantage as well as a clinical advantage versus a suboptimal recanalization, one where there is incomplete revascularization from loss of side branches or slow flow. In these patients, actually a higher cost and an increased risk of 5-year cardiac events as compared to even a failed PCI. So there are certainly cases where it's better to fail than to leave a patient with a suboptimal recanalization. And this takes experience and expertise. So that being said, this is the algorithm that we use when patients refer for CTO intervention. First of all, do they have limiting angina? If not, do they have significant ischemic burden? And this is what leads us down the path of whether or not revascularization is indicated, whether they're a surgical candidate, and if they are not a surgical candidate, they're referred on for CTO intervention. So in conclusion, I would say that advanced CTO PCI techniques are very effective and have an exceptionally low complication rate only in high volume centers. And an effort needs to be focused on selecting patients who are most likely to benefit from CTO PCI. And the main goal, honestly, at this point is symptomatic relief. And to a lesser degree, I think we have some evidence to support reduction of ischemic burden and improvement in LV function, whether it be segmental or global. With all of these limited data, I would say that the biggest thing is that when patients are referred, we need to have a team-based approach to determine who is most likely to benefit. This requires some sound clinical judgment and some honest conversation with the patient before moving on with treatment. Thank you so much for your kind attention. This is my contact information if you have any specific questions for me.
Jay, thank you very much for a very succinct yet comprehensive talk, and then what a finish for us. I just want to ask you, so you think that clinically doing a procedure makes sense in a patient, what about technically, what are the things that you look at? Calcification, age of the occlusion, length of the occlusion, tortuosity. How do you put technical aspect with the clinical aspect together? Sometimes those technical characteristics or the anatomical characteristics sway you one way or the other?
That's a great question, and it's still a challenge today. What we try to do is honestly divorce those two questions. So we find that patients that are referred for the right reasons deserve full consideration. And there are algorithms that have been published to describe the best approach depending on anatomy and clinical factors that you mentioned. But we try to separate the two questions altogether. If a patient has the appropriate indication, we try to find a technical solution for them. Whereas patients without strong indications, we try not to go down that route and emphasize the importance of medical therapy. That
is a very, very enlightening, I think, answer, Jay. Thank you very much. So that what you're saying is if the patient needs it clinically, then I think that we will pull all the stops and bring everything to bear to solve the problem. And I think that's a unique mindset of a current total occlusion experts. That is also strengthens your point that these patients should be referred to a center, because when you go to the lab, you don't say that I gotta get out because I have 5 more cases. You say that I'm probably gonna be here 3-4 hours to get this long tortuous total occlusion with every capability. And I, as a sort of a outside observer of the field, I'm seeing that there is some evolution. For example, the proportion of the retrograde approach may decrease. Sometimes there is more talk about that than this re-entry. Can you just our time is getting shorter, but can you just briefly tell us your technical journey a little bit over the last 10, 15 years?
Sure. I think that these advanced crossing strategies, subintimal dissection reentry and retrograde, these are the techniques that have allowed us to achieve the very high success rates that we're seeing, but it comes at a cost. So in high volume centers that have these very high success rates, you'll see that the adverse cardiac event rates, peri-procedural events also go up. So there's a price to be paid for this. And so that's where the clinical decision needs to be made with the patient. Are they symptomatic enough? Is this worth taking that chance? Because to get it done successfully is going to require a risk of higher peri-procedural events, and particularly with the retrograde crossing. That's where these event rates seem to be the highest. And there are at least 30% of cases that can only be done retrograde. That's at least been our experience and the experience of many large centers.
2 questions. I think that we still have 2 minutes. 1 minute per question. Is there a role for calcium score in deciding management of CTO?
I think that there is. I think that the CT itself really helps in terms of planning, particularly with anomalous coronary arteries. It helps us to identify the length of the CTO. It helps us to identify the quality of the cap in terms of which is the best crossing strategy. So we use it quite frequently. We even co-register the CT on the fluoroscopy on many occasions.
Okay, 1 more question. Is there a difference in need of treatment between CTO depending on the which artery it is, RCA versus LAD or circumflex?
I don't really use anatomy to decide on my decision to treat. I use their symptoms. So symptoms that are refractory to medical therapy is where I make my decision.
Okay, terrific, Jay. Thank you very much for giving your Sunday morning to us, and your wonderful presentation, and many thanks to you and your colleagues. Thank you.
Thank you.
And while we are very appreciative of the hundreds of attendees in an evening, but we're delighted to be able to bring you the entire enterprise's know-how and depth of experience, and we will continue to do that. On 14th of March, we're going to talk about preventive cardiology. On 21st of March, electrophysiology. At the end of the month, on the 28th, valvular heart disease. Early April, vascular disease, and the 11th of April, we're going to talk about heart failure. And I think this rotation will continue with new topics in different areas. Thank you very much for all, and I'm grateful for all the speakers and the moderators. Thank you.